that persistent joint pain, the swelling that makes movement a chore, the stiffness that just won't quit it can be incredibly frustrating, right?
Absolutely.
Now imagine pairing that with a skin condition. It might sound like just bad luck, but it could actually be a sign of something specific we're digging into today.
Exactly. We're taking a deep dive into psoriatic arthritis, or PSA as it's often called.
PSA, right.
It's a condition where the joints and skin are linked, often in ways people don't fully appreciate. Think of it affecting both your movement and your body's largest organ, the skin.
And our mission here, using our source, Psoriatic Arthritis Overview and Management, is basically to give you a really solid understanding of PSA. Good for revision or just general knowledge. We're planning to cover everything, from the basic definition right through to potential complications, making sure it sticks.
And it's crucial to remember that connection to psoriasis. It affects somewhere between 10 and 20% of people with psoriasis.
Yeah, that's significant.
And sometimes, interestingly, the joint issues can actually show up before any skin changes appear.
Oh, really? Okay. So let's lay the groundwork then. Right. What is psoriatic arthritis exactly?
Okay. So psoriatic arthritis is a chronic inflammatory arthritis. The key thing, the differentiator, is its link with psoriasis.
Right, the psoriasis connection.
It brings those classic arthritis symptoms, joint pain, swelling, stiffness, but it's not just the joints. This inflammation can actually spread to other tissues and organs.
Ah, okay.
You'll often hear it called a psoriatic arthropathy, which is just a sort of technical way of saying arthritis linked to psoriasis.
Got it. Psoriatic arthropathy. So we know what it is.
Yeah.
Now, what actually kicks this whole thing off? What's the underlying cause?
Well, the precise cause, it's still a bit unclear, honestly. But we think it's likely a combination of factors working together.
Like what kind of factors?
We're talking genetics, definitely. How your immune system is behaving. And potentially environmental triggers, too. For instance, there's a specific gene, HLA-B27, that's been linked to an increased risk. Doesn't mean you'll get it if you have the gene, but it raises the chances.
So HLA-B27, that's a key one to remember. If someone has psoriasis, then, are they destined to get PSA? What makes some people more susceptible?
Yeah, that's a great question. Having psoriasis is, without doubt, the biggest risk factor, but it's definitely not a certainty.
Okay.
Other things can increase the risk. A family history of PSA, for example, suggests that genetic component we just mentioned.
Okay.
And having that HLA-B27 gene also makes you more susceptible. Interestingly, things like a history of infection or even physical trauma might act as a trigger in some people.
Trauma, like an injury.
Yeah, potentially. It just shows how complex it can be. Beyond that, certain features of the psoriasis itself seem to play a role.
Like what?
Like having psoriatic nail disease, changes in the nails, also being overweight, smoking, those increase risk.
Okay, lifestyle factors too.
Definitely. And having severe psoriasis or psoriasis in specific spots, like the scalp or the skin folds, like the intergluteal or perianal areas, that seems to correlate with a higher chance of developing PSA.
So it sounds less like one single trigger and more like a perfect storm of predispositions and maybe environmental hits?
That's a good way to put it.
So what's actually happening inside the body then? The pathophysiology.
Okay, so the core issue is an abnormal immune response. For reasons we don't fully understand yet, the body's own immune system mistakenly starts attacking healthy tissues.
Specifically in the joints.
Especially in and around the joints, yes.
Yeah.
That leads to the inflammation, the pain, the swelling. But what's really notable about PSA is that it's often multi-system.
Meaning?
Meaning it's not just the joints. The skin, obviously, the nails, even the eyes can be affected by this same underlying inflammatory process.
Wow, okay. Eyes too.
Yes. And while we know this misdirected immune attack is the driver, the exact molecular steps, the precise mechanisms, they're still being figured out.
Right. So if someone comes in with joint pain and maybe they have psoriasis, how do doctors tell PSA apart from other conditions that might look similar? What's the differential diagnosis?
Yes, the differentials. This is really crucial because several conditions can mimic PSA. Rheumatoid arthritis, or RA, is probably the main one.
How do you tell them apart?
Often the pattern of joints affected is different. RA tends to be more symmetrical. Also, certain blood tests, like rheumatoid factor, which we'll get to, can help distinguish them.
Okay, so RA is number one. What else?
Then there's reactive arthritis, which can pop up after an infection, ankylosing spondylitis that mainly affects the spine, but can have overlapping features.
Right.
Enteropathic arthropathy, which is linked to inflammatory bowel diseases like Crohn's or ulcerative colitis. Gout is another one, especially if it's just one joint in the foot that's suddenly inflamed.
Gout, okay. Always tricky.
Definitely. And you absolutely have to rule out septic arthritis, a joint infection, which is an emergency. And of course, in younger patients, juvenile idiopathic arthritis and other childhood arthritis.
That's quite a list. Good to keep in mind for revision.
So switching gears slightly, how common is PSA actually? What's the epidemiology look like?
It's actually more common than many people realize. In the UK, studies suggest anywhere from, say, 6% up to maybe 42% of people with psoriasis eventually develop PSA. That's a wide range, but significant.
Wow, up to 42%.
Potentially, yeah, depending on the study population. The typical age it starts is usually between 30 and 50.
Middle age, mostly.
Mostly, but it really can occur at any age. And as we touched on, roughly 20–30% of all psoriasis patients will develop PSA. Given that psoriasis itself affects about 2–4% of the general population.
Then PSA affects a fair number of people overall.
Exactly. It seems to be more prevalent in Western white populations. And there might be some gender differences in how it presents. Some evidence suggests women might get a pattern more like RA, while men might lean more towards the spinal involvement, the spondylitis. Interesting potential difference there. Okay, so picture this. Someone in their 30s or 40s, they have psoriasis, and they start getting joint pain. What are the specific signs and symptoms, the clinical features that scream PSA?
Well, the core symptoms are that joint pain, stiffness, and swelling we keep mentioning.
Right. The arthritis basics.
Exactly. The joints might also be tender to touch, maybe look red, feel warm. And of course, seeing those psoriasis skin lesions or nail changes is a huge clue.
Okay.
If it's not managed well over time, PSA can unfortunately lead to joint damage, even deformities, and real functional limitations.
So early diagnosis is key.
Absolutely. The diagnosis often happens in those young to middle-aged adults who already have that psoriasis history. A really thorough clinical history and a careful physical exam are paramount.
Are there specific clues doctors look for? Any quick ways to remember them? Mnemonics, perhaps?
Yeah, definitely. Obviously, a history of psoriasis is number one. Then ask about morning joint stiffness lasting 30 minutes or more. Maybe think 30 for stiffness.
Okay, 30 for stiffness. Good one.
Dactylitis, that sausage digit swelling of a whole finger or toe, is very characteristic. Think dactyls like sausages.
Got it. Sausage fingers or toes.
And foot pain.
Yeah.
Especially heel pain, often worse with that first step out of bed in the morning. Maybe first step foot pain.
Nice. So stiffness, sausage digits, first step pain, and then physically examining for psoriasis.
Precisely. Looking for pitted nails, those scaly skin plaques, classic spots are scalp, elbows, knees, sometimes on the limbs too. And the pattern of joint involvement itself is really helpful in distinguishing PSA from RA.
Okay, you mentioned patterns. What are the typical patterns of joint involvement in PSA?
Right. There are several recognized patterns. A common one is symmetric polyarthritis affecting multiple joints pretty evenly on both sides of the body. Think symmetrical, same sides, polylocals many. That's maybe 30–40% of cases.
Okay. Like RA, but maybe different joints.
Sometimes similar joints, sometimes different. Then there's asymmetrical oligoarthritis. Fewer joints, maybe less than 5, and often not matching on both sides. Asymmetrical, different sides, oligo or few, that's about 20–30%.
Fewer joints, uneven pattern. Got it.
PSA can also hit the sacroiliac joints in the lower back sacroiliitis. And a distinctive pattern is involvement of the DIP joints.
DIP.
Distal interphalangeal.
Yeah.
The joints closest to the fingertips and toenails.
Yeah.
That happens at about 10%. Think DIP for distal.
Ah, the very end joints.
And then there's a rarer but much more severe form called arthritis mutilans, which causes quite significant finger and toe deformities. Very destructive.
Oh, okay. That sounds serious.
It is. And beyond the joints themselves, we also look for things like enthesitis.
Enthesitis.
Inflammation, where tendons and ligaments attach to the bone, like Achilles tendonitis or plantar fasciitis. Also synovitis, inflammation of the tendon sheath. Dactylitis, which we mentioned. Nail changes are common. And even eye inflammation, like uveitis.
So it really can affect multiple areas. You mentioned criteria earlier.
Yeah, for formally classifying adult PSA, there are the ACR criteria, American College of Rheumatology. They involve having a certain number of specific features. For kids, it's a bit different, focusing on systemic inflammation, potential artery issues, plus at least one other feature. But that's getting quite detailed.
Okay. So it sounds like the clinical picture is really key. But what about tests? What investigations help confirm PSA?
Investigations are definitely part of the puzzle. They support the clinical suspicion and help rule out those other conditions we discussed. It's usually a mix of blood tests and imaging like X-rays, MRI, sometimes ultrasound.
What do you see on X-ray?
You might see characteristic signs like bone erosion, maybe some new bone formation, particularly in hands and feet. The pattern can look different from REA.
And blood tests?
Key blood tests include markers for inflammation, ESR and CRP, erythrocyte sedimentation rate, and C-reactive protein. These are often elevated in active PSA.
Showing inflammation is present.
Exactly. We also usually check rheumatoid factor, RF, and anti-CCP antibodies. A key point for PSA is that RF is usually negative.
Ah, that helps differentiate from RA, right?
Precisely. Though a small percentage of PSA patients can be RF positive, just to keep things interesting. MRI is also really useful, especially for looking at the sacroiliac joints. It can pick up inflammation, sacroiliitis, much earlier than an X-ray can.
So MRI for early sacroiliac changes. Good tip. You mentioned a few other blood tests earlier, too.
Yes, a few others can add to the picture. ANF, or antinuclear factor, is another autoimmune marker, but honestly, it has limited value specifically for diagnosing PSA.
Okay.
Serum urate, the gout marker, might be high. And remember, gout can sometimes occur alongside PSA.
Right. Coexistence is possible.
If fluid is taken from an inflamed joint, the synovial fluid, it typically shows a high white blood cell count, confirming inflammation. Serum IgA, a type of antibody, is elevated in about 2/3 of PSA patients.
IgA, yeah.
And checking HLA status, specifically for HLA-B27, can sometimes help support the diagnosis, but it's not a routine diagnostic test on its own.
So lots of potential tests, but sounds like clinical assessment is still king.
Very much so. The tests support the clinical picture.
Okay, so let's say PSA is diagnosed. What's the plan? How is it managed?
Management really gets tailored to how severe the PSA is and which parts of the body are involved. For someone with fairly limited disease, maybe just a few peripheral joints.
Peripheral meaning arms and legs, not the spine.
Exactly. For that, the first step is usually NSAIDs, non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, that sort of thing, to help with pain and inflammation.
Standard anti-inflammatories.
Yes, but often needing regular use. So we think about protecting the stomach, maybe with a PPI, proton pump inhibitor.
Good point about the stomach. What else for mild disease?
Steroid injections directly into the troublesome joint intra-articular corticosteroids can work really well for localized flare-ups, and physiotherapy is vital right from the start.
Physio for movement and function.
Absolutely. Maintaining range of motion, strengthening supporting muscles, managing pain.
Okay, what if the PSA is more severe? More joints, or the spine is involved, or that enthesitis?
Right, so for progressive peripheral joint disease, or if there's spondylitis, spine involvement, or significant enthesitis, we usually need to step things up. That generally means starting a DMARD.
A DMARD.
Disease-modifying anti-rheumatic drug. The classic one for PSA is methotrexate. These drugs aim to actually slow down the disease process and prevent joint damage, not just treat symptoms.
So methotrexate is a common first DMARD.
Very common. Alongside the DMARD, patients often still use NSAIDs for symptom control, continue physiotherapy, and might still get occasional joint injections.
What if the first DMARD, like methotrexate, isn't enough?
If that doesn't control the disease adequately, or if someone can't tolerate it, then the next step is often moving to biologic treatments. These are more targeted therapies.
Biologics, like TNF inhibitor.
Exactly. TNF-alpha inhibitors are a major class of biologics used for PSA. There are others too, different monoclonal antibodies targeting specific parts of the inflammatory pathway. Again, NSAIDs and physio usually continue alongside these.
You also mentioned non-prescribing management earlier. What does that involve?
Yeah, this is super important. Non-drug approaches are crucial. Daily physiotherapy exercises are key for range of motion and pain. Occupational therapy can be fantastic too.
How does occupational therapy help?
They help people find ways to adapt daily tasks, protect their joints, use assistive devices if needed, manage fatigue, really practical stuff.
That makes sense.
And lifestyle changes. Stopping smoking is strongly advised. Losing weight, if overweight, can significantly reduce stress on joints and potentially inflammation too. Things like massage therapy, appropriate exercise, they can all contribute to well-being.
So a holistic approach is best.
Definitely. When it comes to the medication specifically, the ideal scenario is often finding one medication, a monotherapy, that manages both the skin psoriasis and the joint arthritis effectively.
Tackling both at once.
That's the goal if possible. As we said, NSAIDs handle the musculoskeletal symptoms. Local steroid injections target specific joints. DMARDs like methotrexate or sulfasalazine are for active ongoing disease. Then the biologics for more severe or resistant cases.
Are there surgical options?
Sometimes, yes. If joints become severely damaged and function is severely limited, surgery like joint replacement might be considered. And for a single joint with really persistent inflammation, a procedure called synovectomy, removing the inflamed joint lining, might be done, usually combined with intensive physiotherapy afterwards.
Okay. So with all these treatments, what's the long-term outlook, the prognosis for someone with PSA?
It really does vary quite a bit, depending mainly on how severe the joint involvement is. But, and this is the important part, with early diagnosis and getting the right treatment consistently, many people with PSA can achieve really good symptom control.
And maintain quality of life.
Yes, and maintain a good quality of life. We also know that treating early-stage progressive disease aggressively seems to lead to a better long-term prognosis. So catching it and managing it proactively makes a big difference.
That's encouraging. Are there potential complications people need to be aware of down the line?
Yes. Unfortunately, like with many chronic inflammatory conditions, there can be complications. The most direct ones are joint damage, leading to deformities and functional impairment if the disease isn't controlled.
Right. The joint issues themselves.
But there are other potential issues too. We mentioned enthesitis and uveitis, the eye inflammation. That can be recurrent. There's also a recognized increased risk of cardiovascular disease.
Heart disease, why is that?
Chronic inflammation throughout the body seems to contribute to atherosclerosis, the hardening of the arteries. So managing cardiovascular risk factors, blood pressure, cholesterol, not smoking, is extra important for people with PSA.
Good to know. Anything else?
Well, the condition can obviously impact work and daily life significantly. And although rare, some more unusual complications like neurological problems or aortitis, inflammation of the aorta, the main artery from the heart, have been reported.
Okay. So it's primarily joints and skin, but with potential effects elsewhere, including cardiovascular risk.
That's a good summary, yes.
Right then. So to wrap up, we've really taken a deep dive into psoriatic arthritis today. Covered the definition, causes, risk factors, how it affects the body, how it's diagnosed and managed, and the potential outlook and complications.
Absolutely. I think understanding that link between the skin and the joints is just so vital. And it really is encouraging to see how much progress is being made in understanding and treating PSA.
Yeah.
Early recognition, proactive management, they genuinely make a massive difference.
Definitely. And for anyone listening who wants to reinforce this knowledge or explore other conditions, especially for revision purposes, do check out PassThemMSRA.com.
And there's also freeSRA.com for more resources.
Excellent. Well, thanks for joining us on this deep dive into psoriatic arthritis.